Hi, uh, a very warm welcome to all of you joining us this ICH webinar dedicated to diagnosis and management of systemic mastocytosis in 2024. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it is my great pleasure to introduce our guest speaker today, namely Professor Prithviraj Bose, who's a professor at the Department of Leukemia at MD Anderson Cancer Center in Houston, in Texas. Professor Bose is very famous, very well known, and his interest in mastocytosis and MPN is well established, and he's highly published. And we are very proud and honored having him with us. I do apologize for the few minutes of delay we had, but this was due to some technical issues related to some of the webcams. But I think now we're all set, and we would like to hear a lot from Professor Bose regarding systemic mastocytosis, which is really an incredible, I would say, orphan disease. But we've seen some fantastic advances when it comes to molecular biology understanding, introduction of new drugs like avapritinib, and a lot of advances yet to come. So without any further ado, of course, it is highly interactive. Please don't hesitate to share your questions, your comments, your suggestions. But now I'll give the floor to Professor Bose. The floor is yours.
Thank you, Dr. Moti. Thank you, everyone, for attending and listening. Thank you for your patience as we worked through some audiovisual challenges. As Dr. Moti said, I'm actually on two different devices, and so the camera might look a little weird, but at least we're ready to go. So the topic I was given is diagnosis and management of SM, what's new in 2024. So what we're going to do is about the first half of the talk will be about concepts, and then the second half will be mostly what is new, let's say 2023 and beyond. All right, so hopefully the slides are moving at your end. And this is basically the data from the European Competence Network on Mastocytosis. Their 2019, actually 2019 data shown on this slide. But just to make the point that systemic mastocytosis has a number of different subtypes, and the vast majority of what we deal with is indolent systemic mastocytosis, as you can see from the pie chart. And then there is advanced systemic mastocytosis, which we will definitely cover in this talk. And that usually comes in three subtypes, mast cell leukemias and systemic mastocytosis with an associated hematologic neoplasm, or SMAHN, and aggressive systemic mastocytosis. So those three are typically the subtypes of advanced SM, although there are some nuances about that I will clarify. And then there is also smoldering SM. It's a very small subset. We'll touch on that as well. And what we will not be talking about today, since it's really not a problem we encounter much in adults, or certainly not something we manage as hematologists, would be the cutaneous mastocytosis and mastocytosis in the skin, which our dermatology colleagues see. So this next slide is just to give you an idea. It's fairly obvious as you look at the sort of on the left. That the advanced subtypes, which are again ASM, which is aggressive SM, MCL or mast cell leukemia, and SMAHN, so systemic mastocytosis with an associated hematologic neoplasm, those three are your advanced SM typically, and their prognosis is clearly worse than the rest. which includes indolent and smoldering, and of course cutaneous, as you see in the different curves towards the top. Now, this is all from the ECNM 2019 data. And at the bottom right, to give you an idea, you can see the survival, median survival expected in aggressive SM, SMAHN, and MCL. These are, I would say, prior to the avapritinib era that Dr. Moti alluded to. But this gives you an idea of what typically we would expect the survival times to be in those three subtypes of advanced SM. Now, WHO criteria for diagnosis, very important to keep in mind. Of course, there is a major criterion, you require that. And if you don't have that, I mean, you require that, and you require one minor criterion, like you see. I won't read through them, but if you have the major, you just need one minor. If you do not have the major, then you need at least three minor. Now, this we have kind of talked about already, so I won't spend too much time on this. Again, remember, the majority of cases we see are ISM. Actually, this diagram suggests 65%. I think it's a lot more than that, actually. At least in my practice, I mean, I think ISM is 90% of what I see within SM, and then the rest being some smoldering and some advanced. So this is an important slide. I actually updated it because these have been updated recently. So these are the B and C findings. And if you look to the right, just to orient yourselves, ISM or indolent SM can have 0 or 1 B finding, but should not have a C finding. And then SSM or smoldering SM again should not have a C finding, but can have 2 to 3 or should have 2 to 3 B findings. And then aggressive SM or any advanced SM where you're attributing the organ damage to the mast cells should have one or more C findings. Okay, so C is for consider cytoreduction, B is for disease burden. Hopefully that is somewhat clear. This is a lot of information on this slide, but this is a disease that can affect various organs and organ systems as shown on the left. But again, important, as you see the B findings and C findings, there's a lot of little details and nuances in there. But again, you do not expect a C finding in indolent and smoldering disease. And the B findings, whether it's 0 or 1 or 2 or 3, help you distinguish between indolent and smoldering disease. Now, this is another slide which is a bit repetitive, but just to reiterate what we just said about B findings and C findings and what makes it aggressive SM or indolent SM or smoldering SM, and then mast cell leukemia. Of course, you require 20% or more mast cells on the peripherals on the bone marrow smear. But the reason I actually show this slide is that it has a very important conceptual point. Now, remember, I told you just a little while ago that the three subtypes of advanced SM are aggressive SM, SMAHN, and mast cell leukemia. Now, the reason that SMAHN is typically considered a form of advanced SM is that the AHN typically drives the prognosis. So let's say the AHN is CMML or MDS or MPN or AML. That usually drives the prognosis and not the SM so much. And that is why typically SMAHN is considered advanced SM. But it is possible, as you see as you look at the very last row on this slide, that you could have an AHN that accompanies pretty much all the different flavors of the SM. So the SM could be indolent, it could be smoldering, it could be aggressive, or it could be mast cell leukemia. So an AHN could simply be there accompanying the SM. So it's not always that the mast cell component is itself aggressive. And that's the point I wanted to make, where the prognosis generally is not very good because of the AHN, but the SM component may or may not be to blame for the organ damage. Okay, so a little bit more about SMAHN. So, these are the common AHNs. You can see they are myeloid in 90% of cases. They can obviously be lymphoid, but usually it's myeloid. The size of the circles tells you what the most common ones are. So this is simply two disorders coexisting, and again, vast majority myeloid. Also important to know that within advanced SM cases, usually you will find SMAHN. Aggressive SM, which is pure SM causing organ damage, is much less common, and also mast cell leukemia is much less common than SMAHN. Now, there are a few points here that you can see on the slide. The AHN can be obscured by the mast cells, and the reverse can also happen. The mast cells can be obscured by the AHN. And what is causing the organ damage is very, very important, because you cannot really call it a C finding. And remember, we listed those a couple of slides ago. You cannot call it a C finding if you don't believe that it is caused by the mast cells. So more on the next slide on that, but it's very important to know what is driving the organ damage. And then the KIT mutation is very much present in both the mast cells and the non-mast cell lineage. So this is an example. So let's say you have SMAHN and the hemoglobin is 8.2. So superficially that's a C finding, but what is it due to? Is it due to the SM component, or is it due to the, let's say, the CMML or MDS or whatever you're dealing with as your AHN? So that is actually critical to tease out, and obviously that's not easy, and that's not set in stone or hard and fast, that distinction. So you look at the mast cell percentage, you look at the tryptase, you look at the blasts, and you try to make a best guess as to which component is causing the C finding, or rather, to be exactly correct in terminology, which component is causing the organ damage. Because remember, the word C finding typically refers to the mast cells causing the issue. So now turning to KIT mutations, well, these are found in the vast majority of patients with SM, and as Dr. Moti was alluding to, this has led to the advent of the new highly selective and potent KIT inhibitors. It's an exon 17 mutation. It most commonly is D816V, and that is by far the most common, but there are some similar ones like D816H or Y, and you can see those occasionally as well. Now, you can also see other mutations which we see in all the myeloid diseases we treat. So, some of these are shown here. And again, remember, these are probably reflecting the AHN in many cases, but they could also be reflecting the mast cell component, because after all, that is myeloid. And to prove the point, some mutations beyond KIT have been found in even indolent SM without an AHN, right? So you can see these mutations in the AHN component as well as in the mast cell component. Now, like everything else, some mutations in karyotype are relevant to prognosis, especially SRSF2, ASXL1, and RUNX1. As shown on the left, any one of these is considered an adverse risk feature, and if you have two or more of these, that's even worse, and that's clearly shown on the left. Karyotype also matters, above and beyond, having the SAR. Obviously, if you have a high risk karyotype with SAR, it's worse. Now, this is a very important conceptual slide. This is from Andreas Reiter in Mannheim, Germany, where he showed that the KIT mutation is not by any means limited to the mast cells. It is really present in multiple cell lines. I was talking about that earlier as well. It can be part of the AHN, part of the mast cell lineage. And also, similarly, you can have these other mutations, and I was just saying this, in both your AHN and in the mast cells. So both are present in both cell lines and not just one or the other. Now, getting into some more clinical stuff, so prognosis, there's 4 models that I'll show you. There are more, and there are more, I think, underway or coming. But this is, for example, the Mayo one. It's called the Mayo Alliance Prognostic System. You're familiar with these in myelofibrosis, where we have at least 8 models. So I'm sure the concept is not new to any of you. But look at the variables in this model. The WHO subtype is important. That itself gets a hazard ratio of 4 and 2 points on the weightage system. So there are other things like age and platelets and alk-phos and certain adverse mutations, which in the Mayo Clinic hands is NRAS, ASXL1, and RUNX1. So not SRSF2, which is which we consider part of the SAR and is more established. But at least in their hands, it was NRAS, ASXL1, RUNX1, and these other clinical variables. But remember, the WHO subtype is critical if you are to use this model. And I would say this model is not very much used. Now, here is another one. Excuse me, just let me make sure we didn't miss anything. No, we're okay. So the IPSM came from the ECNM, the group whose work I was showing you earlier. They have really done a fantastic job and really taught us most of what we know in this field. They've been around for, I think, over 20 years. And they have annual meetings in Europe. So the IPSM is really a model that has 2 I would say versions. One is for the non-advanced, so indolent and smoldering, and one is for the advanced. And you can see the factors listed as well as the separation of the curves. So non-advanced, it's simply based on age and alk-phos. As you can see, that is it. It's pretty simple. And advanced is based on age, tryptase, white cells, hemoglobin, platelets, and skin lesions. But skin lesions are favorable. They're not unfavorable. They get you a -1 on the points system. Then there is the Mars. The Mars is again came out of the work of Andreas Reiter and Mohammed Jawhar in his group. So Mars is a mutation adjusted risk score. So you can see them here. So remember I said SRSF2, ASXL1, RUNX1. Those are the typical ones that are recognized as adverse and used in drug development as well as in the Mars model, as you can see here. So it only looks at age, hemoglobin, platelets, and the SAR mutations. But remember, this is for advanced disease. It's not for all comers. Now, separately, Javier Munoz Gonzalez, when he was in academia in Spain, he's now with Blueprint, who make avapritinib, but he had published this separate model for indolent only. So for ISM patients, and this is what I was alluding to earlier, these are presumably patients with pure ISM, nothing else going on. And even in them, you may find ASXL1, RUNX1, DNMT3A, and he showed that their VAF, if more than 30%, was an adverse factor, as well as beta-2 microglobulin over 2.5 and KIT VAF 1% or higher. So using these, he published a prognostic score for ISM. Now moving into management. So basic management first, right, before we get into the to the fancier stuff with the targeted therapies. So these patients can have numerous triggers. Stress is the most common one, but there are, I find when I talk to my ISM patients, a lot of temperature excursions as causing problems, both heat and cold. I think heat more than cold, at least in Texas. But you see that there can be many other things: food, alcohol, certain medications. Importantly, at the time the COVID vaccines came out, there was a lot of concern, but thankfully those can be safely administered. And then, of course, bee stings, all of these different things. Now, supportive care for these patients, they all need H1 and H2 blockers, or at least that's what I do. And then they typically, next I'll go to things like cromolyn and leukotriene antagonists, particularly if they have GI or respiratory symptoms, respectively. Allergists will sometimes use omalizumab, which is an anti-IgE antibody. Aspirin can be of benefit. Although aspirin and NSAIDs can also be a problem sometimes, but generally a baby aspirin can be helpful. So a variety of different, this is from an excellent review from two of the top allergists in the field, Dr. Castells up in Boston and Dr. Butterfield up in Mayo, Rochester. So cladribine, moving into the therapies that hematologists like us would use. Cladribine has been used. This is, as you see, work from France, long-term safety and efficacy. And this shows you about an even split of indolent and advanced SM. So again, I would not use this in indolent SM, but it has been used. And advanced SM, again, in the KIT inhibitor era, we would need to use this much less, but it could have a role. You can see the schedule, etc. And here are the response rates. So response rates about 50%, no CRs. But this is using what is called the Valent criteria, which are much older criteria, and more to come on that. So here is just one slide to remind you why imatinib does not work in this condition. It obviously has a label, as you know, for patients who do not have the D816V mutation. So in those uncommon cases, it does work at a dose of 100 milligrams daily. And if the mutation status is unknown, at least according to the label, US label, that's also an indication. But I think now with improved testing and higher sensitivity assays, mostly it should not be unknown. You should typically know the status of D816V. And if you have D816V, imatinib is not going to work for the reasons shown here. Now, so moving into the newer TKIs, so we talked about imatinib, then came midostaurin, after that came avapritinib, and then most recently bezuclastinib, and actually not, well, mentioned on this slide, but no, the structure is not shown, is a drug called elenestinib. So the point here is that these are far more specific, the last three, avapritinib, bezuclastinib, elenestinib, far more specific for the target, which is D816V, specifically designed for this target and similar mutations, whereas midostaurin would be more non-specific with a lot of wild-type KIT inhibition as well, but also an approved drug. So just one slide on something very rare. I'm not sure I've seen a case yet, but there is something called well-differentiated SM, where the cells are round and not spindled, where CD25 is negative. You can see this in all the flavors, indolent, smoldering, advanced. You often do not have the KIT mutation, and therefore imatinib is quite effective. So a lot of data on this one slide summing up the midostaurin trial that Jason Gottlieb published 7 years ago now, or 8 years ago now in the New England Journal. So midostaurin, you guys are all familiar, with it from your use of it in AML, where the dose is 50 BID, the dose here is 100 BID, so that's an important difference if patients can tolerate that, which is an important point. But as you can see here, a busy slide with a lot of things shown. On the left, you're seeing the waterfall plots of the bone marrow, tryptase, spleen volume, all these things, the disease markers, disease burden markers going down. You're seeing in the bar chart the improving response over time. In the initial paper, the response rate was 60%. These are pretty much the same criteria as I showed you for cladribine, where it was 50%, and similar to cladribine, really no CRs here with Mido, but 50, 60, so sort of in that same ballpark. Although these are modified criteria, slightly different, but these are not the new criteria which we'll be talking about. You also see the PFS, the OS, the median duration of response. Again, just to reiterate, this is advanced SM we are talking about. We'll get to indolent towards the end of the talk. And then the spider plot showing you that the GI side effects are not improved by Mido, because Mido itself, I'm sorry, I should say GI symptoms are not improved by Mido because Mido itself causes GI side effects. And that's why you see the green portion sort of sticking out of the black portion of the spider plot. Now, overall survival, remember, this is an advanced SM population, so survival is definitely a topic of discussion, more than symptoms, frankly, in this setting. So just to give you an idea of what the median survival was for all these different subtypes, is broken down by the 3 subtypes: aggressive SM, SMHN, and MCL. One more thing on midostaurin, it has been shown that if you have the SRSF2 ASXL1 RUNX1, you do worse. And also on the right, if your KIT allele fraction or VAF, EAB is just expressed allele burden. If that does not go down by 25% or more, then you also have a worse outcome. Mutations, mechanisms of resistance are kind of hypothetical at this point. Now, avapritinib obviously, is big news, has really transformed the therapeutic landscape. So note here that it's a very selective drug, very unlike midostaurin in that regard, as you can clearly tell from the kinome trees, and also a very potent drug, which you can tell from the IC50. So it was studied in 2 trials, Explorer and Pathfinder. As shown here, Explorer was the phase 1, Pathfinder was the phase 2. They're both summarized here. This is all advanced SM. Again, to reiterate that, Explorer was phase 1, so it looked at many different doses. But of course, they tried to expand the 200 to get more data in that setting. Pathfinder looked at the 200 once a day, which is the approved dose. And the response rates in both these trials, at least when Pathfinder had its interim analysis, was exactly the same at 75%. But this uses newer criteria. Important to remember, different and newer criteria than the Mido or the cladribine. And here is more of a breakdown. Again, I won't go through all those numbers. I just told you 75% overall response rate. You see there are CRs, which we don't see with Mido. So you are getting CRs, actually a good percentage. And then obviously, if you look towards the right, if they are Mido naive, they are going to do better than if they are Mido experienced. And you see again, partial remission, clinical improvement, all those things. Important to remember that overall response rate does include CR, CRH, PR, and CI. So this is just, we talked about these things, the different subcategories and the rates in those, and then the Mido naive or exposed. And then molecular remission. So at a level of detection of 0.17% of KIT, the KIT D816V, there was a 30% molecular remission, undetectable, of that. Now, this slide is from Explorer and Pathfinder, so the phase 1 and the phase 2, the evaluable population, which I think was 53 in Explorer and I think 83 in Pathfinder. Although this might just be, this might be an earlier data cut. I don't think this is all the patients in Pathfinder. This is an earlier data cut, but you can just clearly see that in all these 4 measures of disease burden on the waterfall plots, and remember the color coding is just telling you what subtype of advanced SM it is, you can see that you're getting a profound reduction in all these measures. Overall survival, so remember with MIDO we were talking about 28 months. Here we are talking about 47 months. Obviously these are different trials and we should not compare across trials, but obviously we have to do that in this sort of situation. So this is about 47 months, so clearly encouraging, and not reached for some of the subtypes. Now, this is reasons for progression. So just one quick point, these patients usually progress for the AHN, not the SM. So when you see progression, you see the AHN getting worse rather than the SM. Okay, so Pathfinder, important study. Remember, this is a larger study. This is 107 patients in all. 69 with prior therapy, 38 without prior therapy. This is the phase 2, 200 milligrams, more of a uniform dose. So a little bit easier to understand the data for this one. These are just baseline characteristics. Obviously, that's important. So I thought we should have it up there. High tryptase, 312, bone marrow mass cells, 50%. About a quarter of, 36% of patients with one of the adverse SAR mutations. So quite a few, significant disease burden, that's for sure. And then the breakdown is shown with SMAHN being the majority, as you would expect, more than ASM and MCL. So here again, very busy slide, but just note here, I showed you in the phase 1 and in the interim analysis of the phase 2, it was 75% overall response rate, which is CR, CRH, PR, and CI. Here you're seeing 73 with the full data set of the phase 2. So 83 patients now compared to 32 in the interim. Right, so bigger data set, 73%. So in that same ballpark, again broken down by the subcategories. I won't read through those. Again, better if you're treatment naive, a little bit worse if you're not. And then they are also showing you SMAHN separately because that is the most common subtype of advanced SM. Now, in both Explorer and Pathfinder, median time to response is 2 months. Median time to CR is about 9 months. Overall survival not reached. This is about a 2-year median follow-up. So obviously different from Explorer, which has a longer follow-up. Remember there we said it's about 47 months. Here not reached, 26 months median follow-up. Some interesting stuff here. Remember I said the KIT mutation is present in not only the mast cells, but also in the AHN cells. So here what you're looking at is in those patients who had SM with CMML or SM with CEL, you saw reductions in the monocyte counts and eosinophil counts as well. So you're not just killing the mast cells. Now, however, I would not jump to the conclusion that you can just treat your SMAHN patient, all your SMAHN patients with AVA alone. Absolutely not. I mean, there may be situations where you need to give specific therapy for the AHN. So very important to remember that. Adverse events, this has actually attracted a lot of attention. At the 200 milligram dose, which is the approved dose in advanced SM, avapritinib actually can be a somewhat toxic drug. So edema is a very big issue, but again, not a serious issue, but absolutely a very common issue. Cognitive effects can occur, please note that. And then, these are, relatively high doses. So important to remember that. Low grades usually, as you can see, but can definitely happen. And then there was a lot of attention initially focused on these intracranial bleeds. which definitely occurred at rather high rates on the Explorer trial. But once they figured out that, okay, this happens, and why does it happen, and they excluded patients with less than 50 platelets, blood thinners, stuff like that, and also the dose was set at 200 rather than 300-400. It came down to a much lower rate in Pathfinder. Nevertheless, very important to remember, there is a boxed warning on this, so do not use it in patients with less than 50 platelets. A comparison has been made between avapritinib and best available therapy. Andreas Reiter published this 2 years ago in Leukemia, and unsurprisingly, survival was better for avapritinib. This is obviously you're comparing trial patients to real world patients and trying to sort of match and come up with a comparison. So with those caveats, this was like 49 months versus 27 months. Okay, so we'll switch to a different drug, bezuclastinib. This is similar in that it is also very selective for KIT D816V, but the difference is that it seems to lack other targets like PDGFR, and therefore may give you less bleeding, and also does not cross the blood-brain barrier, so may give you less cognitive side effects. So this is from ASH 2023. Now, again, I'll not spend too much time on this. This is an early at this point, but this is the study schema. Part 1, different doses, trying to evaluate the best dose. And then part 2, they've identified 150 a day as the go forward. And then they're also thinking of some other cohorts like adding allowing AZA, for example, adding AZA for the associated hematologic neoplasm. I was just talking about that. You may have to add AZA, right, for CMML or MDS or whatever. So looking at maybe a cohort for that, a cohort for people without measurable C findings, which sometimes can be an issue. Let's say you've got lytic bone lesions, which is a C finding. That's not easy to measure on an ongoing basis. So just some thoughts like that. Good safety profile thus far in the 32 patients shown here. So no related cognitive impairment or bleeding. Remember, those are perhaps the differentiating features of this drug. Low grade reversible adverse events looking good so far. Some liver issues have been reported, as you see in the 4th bullet there, and needs to be watched. Responses, well, a little lower than what I showed you for AVA. Obviously different trials, but in this early assessment of 27 patients, see that the overall response rate is 56. It's not 73, 75 like we were talking about earlier. But you're still seeing, like a 22% CR/CRh, which is just like actually in Pathfinder in the full data set. I think it is 22. So similar, but I think overall lower thus far. Now, transplant has a role, absolutely has a role in advanced SM. This is the only real study that people quote, and this is essentially showing you that the survival was 57% at 3 years. It was actually better for SMA-HN, and that's probably because you're curing the AHN. Like we already do transplant for MF, AML, CMML, whatever. So maybe you're making a difference to the prognosis because of that. And then adverse factors predicting worse survival were mast cell leukemia and using reduced intensity conditioning versus full myeloablative. In the last few minutes, this is NCCN, just reminding you, I just want you to focus on the middle of the slide. Does the SM component or the AHN component require more immediate therapy? That's important, and that's how you try to decide that, will I go with a KIT inhibitor, will I go with HMA, or will I go with a combo, which again has not been studied much, but is, I think, the future. Okay, now very important, avapritinib was approved in May of 2023 for ISM based on this study, the Pioneer study. So this used a 25 milligram dose of AVA against placebo. These were patients who were already on best supportive therapy, which are listed on the left. About 2 to 3 best supportive, at least 2, median 3, they were on. And then obviously being ISM, the focus here was on symptom reduction, which I'll show you. And so Blueprint has devised a proprietary score for measuring symptoms. You know, akin to, let's say, in myelofibrosis, like we have the MPN SAF, they have an ISM SAF. You can see the different symptoms on the right. There are 11 symptoms: GI, skin, CNS, and constitutional. And here are, this is the baseline. I mean, nothing much to remark here. I find this very consistent with what I see. You know, in fact, perhaps more symptomatic than the average patient that I see, with a TSS score around 50 at baseline. But in terms of things like median tryptase, median bone marrow mast cells, median KIT VAF, very typical for what I see. Remember, I said median 3 best supportive care treatments, and then they got avapritinib or placebo. And this is the kind of the bottom line. It was a positive study for mean reduction in TSS, which is shown here. The absolute numbers are not particularly strikingly high, but it was statistically, I'm sorry, significant. And this is just showing you that different types of symptoms improve. This shows you that if you go by the classic TSS 50, which you are used to from MPN, you meet that as well. Both TSS 50 and TSS 30 were met. These were actually the original primary endpoints, and then that was changed to mean TSS reduction. As you may recall, those of you who follow myelofibrosis, from the pelabresib data at the last ASH meeting. So kind of similar story there. So tryptase reduction is shown here. There's no question that this is positive. Same with the KIT allele fraction reduction. So marked differences from placebo, clearly hitting the target here. Extremely well tolerated, so very different from the 200 that I showed you earlier. This is at 25. It's a very safe drug, which is what you need in a disease where your survival is pretty much normal, where you're really not worried about life expectancy. Okay, so last couple of things is bezuclastinib. I already introduced you to this drug. This has also been studied in indolent and smoldering. This is all from ASH, so sort of the hot of the press stuff. So this is the study schema. There were just 2 formulations, just keep that in mind. The results I presented in San Diego were on part 1A, which is just a different formulation from part 1B. And the doses are slightly different, 100 and 200 versus 100 and 150. So far, 20 patients, clean safety profile. Again, this is a dose finding stage of this trial, but really nothing of major concern. One patient did, though, have a liver issue, which is noted here. And then the drug is hitting its target very well. You can see tryptase, VF, and mast cell burden in the bone marrow all going down on the waterfall plot. So again, clearly a drug that hits its target. And then symptoms is what matters in this disease, in ISM or SSM for the most part. And here we are showing you quality of life. And then remember, I said the ISM SAF is proprietary to Blueprint. So this company, being a different company, they used an older scale called the MAS. I think it's called mastocytosis activity score. There we go. It's on the slide. It used that one to assess. And then this is the very last one. So Blueprint has a successor drug called elenestinib, which is also like bezuclastinib, does not cross the blood-brain barrier, and is also very potent and selective for the mutated KIT. So they also presented results at ASH, and this is their also dose finding portion. So for 3 different doses or placebo, small study at this point, 39 patients. And they also showed that this is a well-tolerated drug, low-grade adverse events, and they're looking at also a go-forward dose, I think, which is I think that perhaps remains to be seen. I'm not sure that was decided on yet. but that is to come. And then they also showed here that, regardless of the dose, actually, all the 3 doses that they tested in this part 1 actually hit the target as far as tryptase, KIT, VAF, and bone marrow mast cells without a significant difference. So all 3 doing better than placebo and sort of non-significantly different. So I think that is the end. This is just one last slide on symptom improvement. Obviously, I misspoke. Let me just correct that. So my comments regarding non-significant differences were here on the symptoms, not on the disease markers. But the symptoms did not seem to be significantly differently altered by the 3 different doses. They're better than placebo, but that's about it. So more to come on this trial as it moves into part 2 and whatever dose is ultimately chosen. I will end by saying that the bezuclastinib, which I just showed you before this, will be read out next week at the main allergy meeting in the US, what's called the QuadAI, American Academy of Allergy, Asthma, and Immunology. And there, the bezuclastinib part 2 data will be out with the chosen dose to go forward with. And that is the end. Thank you very much, and happy to take questions.
Thank you very much, Professor Bose, for really beautiful and very nice, comprehensive lecture and very up to date. I mean, even ongoing trials and data from the last ASH meeting. We're very grateful. We have a lot of questions. I'll try to structure them. First question, a series of questions related to the diagnosis. And I think many people struggle with the diagnosis of mastocytosis, and these patients usually would see lots of physicians and healthcare professionals before being diagnosed. And the question is whether you have any tip or something that would allow to detect or to suspect these patients, the diagnosis very early. And because obviously their quality of life is sometimes very, very difficult.
Yeah, so this is absolutely a problem here as well. I mean, I personally have patients who've gone many years without being diagnosed and just, trying to research their symptoms and going to different providers. I think a lot of it is awareness, frankly. You certainly cannot diagnose it just by, just based on the symptoms, but at least they can alert you that this is a possibility. And maybe checking a serum tryptase and checking a peripheral blood D816V, which can be done, right, with digital droplet PCR. That's a highly sensitive assay. Maybe doing that can at least put you in the right direction in many of these patients.
Excellent, thank you. We have a question from Dr. Khanna, whether there is any connection between c-KIT 816V mutation and systemic mastocytosis and c-KIT 842 mutation seen in GIST.
So, okay, I mean, correct me if I'm wrong, but my understanding was that D842 is a mutation in PDGFR. So I don't actually think it's a mutation in KIT. Now, GIST can, of course, have several different KIT exons which are mutated. So absolutely, GIST is primarily a KIT mutated disease, right? But I think the specific mutation the person asked, D842V, is a PDGFR mutation. And avapritinib actually is indicated, has an FDA approval for D842 mutated GIST. But that's in PDGFR. And also some of you probably deal with, the eosinophilia with PDGFR rearrangement, right? Where we typically use imatinib, but this D842V can be a resistance mutation to imatinib. Even in that setting, in eosinophilia with, the CHIK2 deletion, the PDGFRA FIP1L1, and there also, avapritinib could have a role.
Excellent. Thank you very much. So we have a real-life case submitted by Dr. Guluyev saying it's a young lady, 66-year-old, bone marrow diffuse mast cell involvement, 3 lines, with very low counts, reticulin grade 3 fibrosis, anemia, 80, thrombocytopenia, 80,000, and pathology reports mast cell leukemia or advanced systemic mastocytosis. What do you think about this case, and what would be your ideal management?
Well, that case definitely sounds like advanced SM because you already have a C finding of platelets less than 100. And I think you mentioned that the bone marrow has a lot of mast cells, right? So you can actually attribute the thrombocytopenia to the mast cells. Because remember, like I said, it's important to know that the C finding is attributable to the mast cell component. So this case sounds like a case where I would use avapritinib. Platelets are 80, right? They're not less than 50.
Absolutely, 80.
Yeah, so no, I would use it, but of course, you could see, unfortunately, with all these drugs, you see some degree of wild type KIT inhibition. So you will get some myelosuppression. So you have to be careful and dose reduce and all that.
Perfect. Thank you very much. Another question from Dr. El-Yamani about the role of avapritinib in KIT-negative systemic mastocytosis.
Yeah, so see, that comes up not infrequently. I have patients myself who are indolent, though they are not advanced, but who don't have the KIT mutation, even if you use the digital droplet, which is what is recommended. So it's hard for me to justify these drugs in that setting, although the trials, as you may know, have not excluded them, right? So sometimes we offer the trials of, let's say, bezuclastinib. I have that at my center, but it's probably not the ideal approach. So, I've done imatinib even in that setting because of its, old label of, use in wild type or without the D816V. Um, and now this is really very recent, but there is a trial that has opened of a BTK inhibitor. This is super new. This is I think only a few centers maybe. It has just opened. So again, I cannot recommend that obviously, but I'm just letting you know that non-KIT approaches are starting to be explored.
Okay, wonderful. Thank you. One other question from the audience. You mentioned elenestinib as the sort of next generation after aprivitinib. But do you believe that one would overcome the resistance to another, or is it more improving the safety or the efficacy? What's the difference between these two agents?
Well, I will also include bezuclastinib, and I'll say that elenestinib and bezuclastinib are probably this newer wave of or second generation, however you want to call that, of mutant KIT inhibitors. But you're right. I don't necessarily expect that one would overcome resistance to either of them would overcome resistance to AVA, true resistance. But rather, I think if someone is intolerant to AVA, or let's say, or let's say, for a better safety profile, as you already said, I think that is where the drugs would fit.
Excellent. Thank you very much. One last question, because we're already 1 minute past the hour, about the role of allogenic stem cell transplantation in these patients, and actually whether, for instance, a drug like aprivitinib can be used as a bridge to transplant, but also for maintenance after transplant, because obviously transplant is not going to solve all the problems for these patients.
Yeah, maybe not. I mean, again, I showed you the only one large study, 57% 3-year survival. We're talking about advanced SM, of course. You would not transplant indolent. But, I'm sure that AVA could be a bridge to transplant, just like Rux is in myelofibrosis. But maintenance with AVA, again, theoretically makes sense. I think we are already there with FLT3 and BCR-ABL, right? We are already there where we are using those drugs as a maintenance. We're not doing so with Rux in MF. We're not yet there with Rux. So I think it remains to be seen. I mean, these are studies that need to be done.
Excellent. I believe uh, this has been really a terrific webinar. Once again, I'd like to thank you, Professor Bose, for really for your time and for sharing your knowledge and wisdom, I would say, in this difficult and hard to treat disease. But thanks to the advent of many new drugs and really cutting edge research, I believe the outcome of these patients will continue to improve. So thank you all for following the ICH activities. Thank you for joining us today. As usual, all our webinars are made available on demand on the Academy website, clinical-hematology.org, because I had a couple of questions about whether this webinar has been recorded. So yeah, you will be able to see the broadcast in a couple of days on the Academy website. But for now, I'd like to say thank you to all of you, and wherever you are, please stay safe and keep well. See you soon.
Thank you for having me. Thank you.